Thank you, team. A very good evening, everyone. I'm Dr. Rajashri from the medical team. Before we move ahead with today's program, I'd like to give you an overview about Genova Images. At Genova, we believe in transforming healthcare through innovations, collaboration, and education. We can proudly say that over 10 years, we have made a difference in hundreds of thousands of human lives, and over a decade, we plan to multiply it with thousands. Since 2 decades, we have brought to you a wide range of therapeutics catering to diverse therapies as well. And without further delay, I would like to kindly introduce you all to our today's speakers and director. Uh, it is my privilege to introduce our program director, Dr. Baman Thaver sir. He is a distinguished name in the oncology community, associated with Fortis Hospital, Mulund, as a senior medical oncologist. A warm welcome to you, sir, on behalf of Genova family.
Thank you. Thank you.
We have Dr. Deepak sir as a moderator. He's a medical oncologist associated with Indus Group of Hospitals, Punjab. Also, he's sharing one of his cases with us today. A warm welcome to you, sir, from all of us at Geneva.
Thank you so much. Thank you, Dr. Rashri, and good evening, Dr. Bowman. And
good evening.
Good evening, Dr. Jayashankar. And hello, Jehan, how are you?
Hi, Dr. Deepak. Hi, fine.
So, joining with us as a speaker, we have Dr. Jehan Thaver, sir, medical oncologist associated with Just Look Hospital, Mumbai. A heartfelt welcome to you, sir, on behalf of Geneva family.
Hi, thank you so much. Thank you.
So we are privileged to have an esteemed panel of experts with us today. Dr. Abhishek Raj, medical oncologist, Sarvodaya Healthcare, Faridabad. Dr. Avinash Upadhyay, medical oncologist, Mithila Care, Cancer Care, Patna. Dr. Jaya Shankar S, medical oncologist, Bill Road Hospital, Chennai. Dr. Mukesh Chaudhary, medical oncologist, HCG, Manavata Hospital, Nashik. Dr. Roopjyoti Sharma, medical oncologist, State Cancer Institute, Guwahati. Dr. Rushabh Kothari, medical oncologist, ongoing hospital, Ahmedabad. Dr. Saurabh Radhakrishnan, senior consultant and faculty, Amrita Institute of Medical Sciences, Kochi. And Dr. Shrivalli A, medical oncologist at Manipal Hospital, Bangalore. So without further ado, I would request Dr. Bowman sir to take over. Over to you, sir.
Yeah. Thank you very much for giving me this opportunity. Today we are going to have a lot of discussion on neuroendocrine tumors, I'm sure. As you all know, neuroendocrine tumors have a very diverse clinical manifestations, histopathological manifestations, and really how to treat each of them individually when we see a person or a patient in front of us. That's a very challenging job. It can be grade 1, grade 2, grade 3, well differentiated. We have got neuroendocrine carcinomas, of course, which are a part of neuroendocrine neoplasms, I would say, but we are not going to discuss that. And what today we'll be discussing is on neuroendocrine tumors. So I'll now request Dr. Deepak Shingla to go ahead and tell us something more and go ahead with the meeting.
Yes. Good evening, sir, and thank you for this opportunity, Dr. Dhabar, and thank you for your kind presence. I think Dr. Jihan has to present the first case, or shall I start with that?
I'll present it, no problem.
I mean, because in the schedule, first cases belongs to you.
Okay, yeah, I'm good to present, no problem.
Okay, right.
Yeah.
So please, so Jihan is sir, as already Rashid has introduced that he's a medical oncologist with the Just Look Hospital. So Jihan, is to you.
Yeah, thank you. Hi, good evening, everyone. So today, my case is a little bit different from our classical neuroendocrine tumors that we see, but it's one of the spectrum of the neuroendocrine tumors. So I'll be talking about a esthesia neuroblastoma that I recently treated. Next slide, please. So it's a very long-standing history. So the patient herself is a senior consultant, a doctor from one of the hospitals where I'm attached to, and she's a known hypothyroid, and she has a strong family history also. The patient's aunt had colon cancer. The patient's real sister had breast cancer. She's of course postmenopausal. So in 2009, she was first diagnosed with anesthesia neuroblastoma. She was operated in Delhi that time and received local RT. In 2011, she developed bilateral cervical nodes and she underwent the radical neck dissection. That time, the histopathology was suggestive of a metastatic neuroblastoma with deposits of some papillary component and thyroid involvement. In 2012, she received post-op adjuvant RT and she was started on injection octreotide that time monthly, and she is on octreotide till now, till 2025. In 2012, she underwent a DOTA PET, which was all clear. And in 2019, she had some bony pain, persistent back pain, and a repeat DOTA PET was done, which showed extensive skeletal mets and also multiple lymph node metastasis. Next slide. So the patient was on octreotide, as I mentioned earlier, and also along with for the bony met, she was put on denosumab, and she was started on PRRT with lutetium dotatate, and she received multiple second cycles of at least 4 cycles of lutetium therapy from August 2019 to 2020. Uh, in 21, she also her history was quite patchy. She had received some radiation again to the cervical lymph nodes and also to one of the bony lesions in her cervical spine because there was an impending cord compression at that time. So she received palliative radiation to the cervical spine as well. In 2021 is when she came to me with progressive disease, and I got a fresh biopsy done because we had no tissue diagnosis right from 2009. So, and also the fresh biopsy was suggestive of a esthesioneuroblastoma only. In between, she had also received some actinium therapy from our nuclear medicine specialist. Next slide. So, the point of doing the fresh biopsy in 2021 was also to get an NGS done, a next generation sequencing with the MSI, PDL1, and everything done. Unfortunately, her NGS was negative. She was MSI stable. PDL1 was negative and had a HER2 zero disease. And octreotide and denosumab was continued. In 26, she had some progressive disease, and but she was still asymptomatic, and we just kept her under close follow-up. Now, in September 25, she has persistent epistaxis. She has significant weight loss, and as expected, her Dotanoc PET is showing further disease progression. Next slide. So this is just a short, take-home message on esthesioneuroblastoma. So this was first described somewhere in 1924, and it arises from the olfactory neuroepithelium, and it's less than 5% of cyanogenal tumors can be esthesioneuробlastomas. They are usually seen in the second decade of life or in the fifth and sixth decade of life. And these are one of the small round blue cell tumors that we know of. Next slide. This is how the staging system is. We have the Cardis staging system, and then we have the Dulgerov staging system, which is a TNM based staging system. Next slide. I will not go into all of the histopathology details. Next slide. So this was one landmark paper that I found on neuroblastomas for olfactory neuroblastomas and what treatment recommendations that we can offer. Next slide. So just to summarize, so we have an elderly patient. She's 77 as of now. She's been diagnosed in 2009. So a very indolent disease. Biopsy proven to be esthesioneuroblastoma. She received extensive PRRT with lutetium, with actinium. As of now, as of current date, she is being planned for a terbium-based PRRT therapy at Tata Memorial, and where I'm also contemplating to give her small dose of a platinum-based chemotherapy. She's too frail for a platinum doublet, so I've just planned a weekly carboplatinum with or without maybe Avastin. Next slide. There's also some literature about using TKIs with sunitinib everolimus, pazopanib for esthesia neuroblastomas. Next slide. And this is just why VEGF inhibitors can be useful in these subgroup of tumors. As I said, there is literature for sunitinib, pazopanib, lenvatinib. Because the VEGF blockade mainly can inhibit tumor angiogenesis, it reduces, as we all know, reduces tumor blood supply and eventually will lead to cell death. Next slide. So from the chemotherapy point of view, there is strong data for etoposide cisplatinum or etocarbo. And as I said, our patient being 77, extensively treated with nuclear-based therapies, just a single agent chemotherapy with carboplatinum may achieve some disease control if at all. Next slide. And I have no personal experience with a terbium-based PRRT. If anybody in the panel or anybody has any experience with terbium, I would also be glad to know something about that as well. Next slide. Yes, next slide. That is it. So this is what she's been planned for. She's been planned for a terbium 161 based PRRT. I did find some literature where it can be used for patients who have progressed on a lutetium PRRT. But again, the data is not quite strong. This patient is going to start from Monday, in fact. So let us see. I will also know how she responds to it and how she tolerates it also. Next slide. So this is my last slide. So this is what the options we have for treating this particular patient. And thank you so much for a patient listening.
Bowman sir, you are on mute, sir, if you are speaking.
Have you done PDL1, Dr. Jan?
Yeah, so we have got an NGS with MSI, PDL1, HER2, everything is
There is
negative
some
one.
literature on immune checkpoint also.
Yes, absolutely, there is. And the whole point of that 2021, we got a fresh biopsy done for sending it for the entire molecular panel and PDL1, which was all negative.
Okay, Jay, I have one question to you. Did you get the biopsy this time also in 2025 when she got?
No, this time we have not got a fresh biopsy done. But one more thing I forgot to add in this PPT. She came recently with pleural effusion also, which was in a PET, and a cell block is showing atypical cells. So I'm awaiting that IHC. So we'll probably have some
And what is
tissue
NGS?
diagnosis.
NGS is showing what?
Nothing, absolutely. Nothing.
No FGFR, nothing.
Nothing at all. So, and they have consulted in Tata, and then she's going to start a terbium-based PRRT from tomorrow, from Monday. And meanwhile, the family was keen to start some chemo also, but will she respond and tolerate at the same time is something.
Okay. And what is the CBC like? How is his like,
She's having persistent epistaxis, so we have given her a hemostatic radiation right now for the epistaxis. And because of the epistaxis, her hemoglobin was down. As rest of the CBC picture is okay. Her WBC, platelets, and all are okay.
Okay, right. Okay, right. So it's not.
Let's go ahead now.
Yeah.
Thank you very much, Dr. Jayan. Now let's go to the next presentation. Dr. Deepak is going to.
Yeah, thank you so much. Thank you so much, Genova team. So, sir, my case is very simple actually. So, I will be doing the panel discussion as well as this case presentation. And this guy is because my practice I am located in Punjab. So this patient has came to me from Roped. So this is a 55-year-old gentleman, ex-serviceman, presented with pain abdomen for last 3 months, And what he was telling that he was having a episodic in nature pain abdomen. It is not persistent, but it is episodic in nature, which is associated with a lot of anxiety. Okay. So he was telling me in Punjabi that एपिसोडिक कभी कभार दर्द होता है और बिल्कुल जब होता है तो बहुत ज़्यादा मेरे को घबराहट होती है. Otherwise, his appetite was good, performance status was one, and uh, at when he consulted the physician or local surgeon there, they got the CCT abdomen done. It was showing the multiple liver space occupied lesion, multiple. Then he was referred to us at our hospital. So at the first go, I did not suspect to be suspected to be a neuroendocrine tumor. So as usual, when I found the CCT abdomen, multiple liver as well, I subjected him for the PET CT scan. Next slide, please. So PET CT was showing ill-defined hypodense lesion in both the lobes of the liver, suspicious for mitotic activity. Then we went ahead with the liver biopsy, which was showing the neuroendocrine tumor of grade 2. Mid-gut ISC was suggestive of mid-gut in origin. CK chromogranin synaptophysin was strongly positive, and he turned out to be SCV also positive. Then I subjected him for for a gallium DOTA scan, which was suggestive of low-grade SSTR expression along the dilated appendix with appendicolith associated with the mid-mesenteric haziness and peripendicular nodularity. Multiple liver lesions suggestive of mitotic involvement. So I have sent the chromogranin level also, but I could not trace that. I was not able to trace that. So this is the basically short story. So I just want to ask my panelists. So can you proceed with the next slide, please? And so this is the basic scan which we got it done last year when he presented to me after getting the PET scan, which is clearly suggesting of big big liver metastasis, big two rounded liver metastasis, as well as peritoneal deposits. So I want to ask my panelists: is there anything other, Dr. Bowman, can we do? Dr. Jayashankar, can you take that? Any other things we have missed?
What is the KI67?
Sir, KI67 was approximately 2%.
2%.
Yes,
So if it
2%.
is 2%, it is just grade 1 or 2.
Yes, sir. It was grade 1 or 2. It was grade
Yeah.
1 or 2.
Okay.
Yes.
And it's a well differentiated NET.
Well, very
Well
good. Well differentiated, sir. There is yes.
And you are telling us mid-gut because on the DOTA text you saw uptake.
Yes, a daughter talk, and we did a colonoscopy also.
Acha, okay.
We did a colonoscopy. It was there is a mass in the ileocecal region,
Okay.
ileocecal region. But when they did the biopsy, they they couldn't take the proper biopsy, so it was
Okay.
non-conclusive. But we suspected that it is from the ileocecal junction only, which is the most common site. Yes, sir. Uh, Sir, Dr. Jayashankar, you want to add something? Is there anything else we could have done, sir? I think he's
Uh,
muted.
no, sir.
No.
So it's a basically neuroendocrine tumor, grade 1 and 2, midgut region primary with liver secondaries.
Yes, sir. Yes, sir.
So already ISC everything done and diagnosis confirmed.
Yes, sir.
So next we'll proceed with the management, sir.
Yes, sir. Actually, the patient was well preserved. All the biochemistry was also, routines. His labs were also well preserved. But the only reason was to start the treatment was only he was symptomatic. Okay, he was getting the pain abdomen episodic, and top of that he was because of the catecholamine rush he was getting a lot of anxiety, flushing and all that. So we have started him on octreotide LAR, and this scan was done in last year March 2024. And next slide please. So let me show you the this now this is the you can see on my right side. Right side is a basic scan, and this is the after giving the treatment. So we can see that there is a very good response after giving the this sandostatin LAR 30 mg on the
How
monthly
many?
basis, and
How many?
patient is
How many
sorry.
doses were? How many doses were over by this
Uh,
time?
Sir, it is more than now, more than 12.
12.
More than, I mean, still we are maintaining that.
And urinary 5-HI was normal.
Sorry?
Urinary 5-HI was normal. Urinary
Uh,
5-HI.
Sir, actually, because today I could not retrieve that
Okay.
reports, chromogranin and all that reports, I couldn't retrieve that. Basically, this scan copy I retrieved from my nuclear medicine fellow. I mean, from the, so I could not, but
So,
once
so
the,
any patient who has got symptoms, one should do a urinary 5-HI levels also.
okay, right,
That,
right,
that's
sir,
the
right.
take home message. Yeah.
Okay, yes, sir, we did that, sir,
You must
24
have,
hours.
I'm sure. I'm sure you must have.
Yes, sir, but I couldn't retrieve that report. But sir, once the patient is, ISC proven, is there anything else we required, sir? ISC proven
I
grade.
speak on. Yeah.
Okay,
Yeah.
had he been asymptomatic, or he was not having any symptom, he just on ultrasound, if he got the SOLs, should we have been treated, sir? Dr. Abhishek, for asymptomatic patient.
Sorry, sir. One more time, can you come again? I'm just outside, actually. Yeah,
Okay, Abhishek, I just
yeah,
wanted to ask because I started the treatment.
yeah.
Otherwise, patient was well preserved.
Anjali.
Had he been asymptomatic, no pain abdomen, no flushing,
Mhm.
should we start the treatment in such scenario? Do we start the treatment?
I,
Do
I usually do. I do not wait for I do not
symptom
usually wait for the symptoms to happen. Even if it is
symptom?
asymptomatically detected, already metastatic, we can see there are nodes in the peritoneum, deposits
Yes,
are
yes.
there in the liver. We usually
Uh-huh.
start treatment. Another
Uh-huh.
thing that I would just briefly like to add that there are certain, like sir was mentioning, that there are certain patients who are very symptomatic. So much so that if the patients are having a lot of diarrhea, sometimes even we see that there are some cardiac symptoms as well. The right-sided heart failure symptoms are there.
Yeah.
In those patients, I think short-acting octreotide for a few days, admitting for a few days, giving them short-acting octreotide, that works slightly faster, and then eventually we switch to the octreotide LAR. So that has been my experience, and the situation can change on a patient to patient basis, considering the trial of PRRT now coming in the first line has now been there. But even for asymptomatic, I am starting treatment.
Okay.
Yeah.
Point well taken. So we should not, when the patient is already having a large hepatic metastasis, and we should not wait for the, even the patient is asymptomatic, we should not wait for the symptoms to
Right,
appear. Okay,
right, right,
okay.
right.
That's a good point. So now the patient is asymptomatic. Now question is how long we should be, Dr. Bowen, we want your inputs that how long we should continue with that. Finances are not issue. Is sponsored patient, ex serviceman, ECHS patient, there is no problem, and lives commuting to I mean commuting is also not a problem. Hardly lives 1 hour away from our hospital.
Now,
Uh,
So,
what about liver lesion, sir? Liver,
Sir, but I mean, it's it's suppressed now. Very well responded, sir. Very well responded.
I
okay,
think
sir.
so.
If it is a resectable, residual liver is there, no, then we can go ahead with surgical resection also, sir.
Sir, will there be any benefit of doing that because it's a disseminated disease, sir?
Mhm.
Dr. Bowman, is what is your input into that?
Yeah.
Because see,
Uh,
liver is also sorry, sir. I just want to make there are two big lesions. Apart from that, there are multiple tiny lesions are also there, sir. I mean, we can see that in the right side because the right lobe is almost more than 70% is studied. Will there be any benefit of doing surgery?
I said, see, tumor debulking is important only if there is a carcinoid syndrome and there is a major disease in the liver. Then some form of debulking, that can be either TACE or tear or tumor, that may be a good option. But this, our patient is not really symptomatic from carcinoid syndrome point of view. So he has no major carcinoid syndrome. What he has is just multiple, he has got a large tumor bulk. So I would continue this treatment till disease progression. Toxicity we hardly see. What are the toxicities of somatostatin? I'm sure all of us know gallbladder stones or something like that, or
Mhm.
diarrhea or some, or there is no major toxicity with somatostatin. So I would continue somatostatin. I have got patients who are there on somatostatin for last 3 years, 4 years, and they're leading a good, comfortable life, I think so. So
very much comfortable, and he's back to his daily routine after 2 3 months. He's back and he's very happy with the treatment. So Dr. Jay Shankar, so I we think that we should withhold. I mean, meanwhile we are not thinking of surgical resection, so because the patient disease is well controlled, patient is asymptomatic. So any thought on Abhishek, you want to take on any what is your opinion on surgical resection? I think who else is there apart from Abhishek? Dr. Saurav?
Yes, sir. Yes, sir.
Yes. So,
I'm here.
what is your take on surgical resection in your practice when you proceed with the with surgical resection, and whether
Uh,
patient?
s-
Huh.
so in a the so sir, if I have a very young patient, liver limited disease, so
Hmm.
generally even for oligometastatic disease, I usually start the treatment with a sandostatin LAR only. And I usually tend to study the disease biology. If I see that okay, after 6 months period of time, one year period of time, there has been a good response and that response is maintained. So that is when I probably counsel the patient for going ahead with a definitive or a curative intent therapy. Because if you straight away go for surgery and then 6 months later he develops a new metastasis in liver again, it is really challenging. So it is very important to study the role of disease biology as well as discuss the case in an MDT meeting before taking the call on a curative intent setting in a limited metastatic setting.
Okay, okay, right. So first of all, disease control is a must, and we should see that how the disease is behaving, right? And even if we do the section also, can we withhold the sandostatin LAR? Can we withhold after that?
I have done that, sir. I have done that in a few patients because some of the patients, like he's also one of my ECHS patients coming from Uttarakhand.
Uh,
He had a very good response after 2 years of therapy. He had a liver limited disease. We did the resection. We decided to continue the sandostatin after that also, but he was really fed up. So eventually we discontinued. I think he's still on follow up, 2 years follow up. He's still in remission, no disease.
okay, okay.
uh,
Dr. Bowman,
yeah,
Bowman sir, your inputs, please.
yeah. See, if after a good response, if the SSTR expression is no longer there, you can consider stopping somatostatin.
And
If there is,
one more.
if the SSTR expression continues, we can go on giving somatostatin. And if there is an
Okay,
improvement, clinical improvement. So there is
Just
beyond progression also one can consider if the expression is there on
yeah,
progression.
just one more point. I think we know that sandostatin is something which is not tumoricidal. So that is why the data for adjuvant sandostatin has never come up. Even in
Correct.
a case which is completely resected, there have
uh-huh.
been trials, there have been 2 3 trials which have tested for the data for adjuvant sandostatin. It has never shown
Yeah,
survival benefit.
exactly.
So if you're able to address the entire thing, I think you can safely stop sandostatin in such patients.
Dr. Shiravali, any inputs from your side, ma'am?
Sir, I think I feel like Dr. Abhishek was telling. I similarly had a patient. Initially, they presented with actually obstruction and then with liver metastasis. So, because of the obstruction, we had to undergo. She had to undergo upfront surgery. So, post that, we continued on octreotide. One year did really well. Liver also, there was a very good response. There were only some two lesions. So, post that, we planned for metastatictomy as well. Post that, she continued for 6 months, then she disappeared. She was like, I'm also fed up with the injection because it's an IM injection. It's been 2 years and she is disease free. So I think each patient is different, but yeah, but upfront the patient was definitely a metastatic. So I think, like even Bowman sir said, there is an expression we tend to continue because when they ask a question, will the disease come back? We have no answer. So otherwise, monitor with serum chromogranin and see an increasing trend, then probably restart. I think it has to be decided patient to patient basis.
Okay, very nice, very nice.
I'll
So
just make one thing. What you said is absolutely right, but chromogranin on somatostatin becomes a poor marker usually. So it's a very poor marker on the treatment. So you don't take generally decisions on chromogranin. That's just an input I'm giving.
Yes, sir,
okay,
absolutely, you're right. But when the patient asks, at
Yeah.
least, I mean,
Yeah.
to convince them that this is at least raising, please start.
It's like CA 125. The patient will see the chromogranin
Yes.
level and come to you.
Yes, sir, yes.
Okay, Dr. Rosav and Dr. Saurav, your inputs, please. Avinash.
Hi, I'm Avinash. So, what I believe that if the disease is limited to liver, it has responded, and now you want, then only we can go for surgery. Upfront, definitely medical management helps. Sometimes in a patient when only disease is confined to liver, there is no other disease, and you have seen you have octreotide is now not working, then also we can go for and we can go for local therapy like taster, or we can just go for ablation.
Okay, okay. So, sir, another reason of not considering for any surgical intervention there because there was a multiple lesions,
Dysentery in the dysentery.
multiple SOLs in the liver. So, although I mean 2, 3 are the bigger one, but there were so many, entire liver was flooded with the metastasis. So, I mean, we did not consider that, and the patient is asymptomatic and he's happy to come. So, so we are continuing with that. So, this is the next slide, please. Just starting with my panel discussion. I'm having the all the entire uh, team of my panelists from all over country. Let's start. Next slide, please. Sir, I will start with Avinash. So, what are the most common presenting symptoms of neuroendocrine tumor in your clinical practice? Okay.
So, hi. So many a times, what I have seen that the patient will be going for routine this examination, and the patients have come with multiple liver as well. So I have seen multiple times that also. Many a times they come with the presentation of the hormone which they are secreting. So flushing, redness, diarrhea. These are all other common presentations like abdominal pain and all. So various presentations. This asymptomatic presentation also I have come across quite occasionally, like the patient's not having any symptoms but the liver is having multiple as well. So these are things which I have seen in my practice.
Okay, very good. I mean, so the symptom basically depend upon the site of the, I mean, site of the lesion from where it is
Yes,
originated
yes,
and
yes,
from
exactly.
which hormone it is producing. Dr.
Produce.
Jayashankar, any inputs? I mean, from your side, Dr. Jayashankar, sir.
Most of the time, we also seeing asymptomatic patient only, sir.
Symptom.
Symptomatic patients very rare. But if symptomatic patients, we can detect early. Uh, One patient presented with uncontrollable diarrhea, other
Hmm.
symptoms. So then we presented with imaging and endoscopy. So we found any neuroendocrine tumor, grade 2 tumor, is there in the second part of duodenum.
Okay.
So second part of duodenum. So
Uh,
initially he went to 2, 3 doctors. So they told need to do Whipple's like that. We have to remove pancreas and duodenum like that. Then we decided to go with the endoscopic resection. Then we did an endoscopic resection of 1 centimeter, 2 lesions from the second part of duodenum. And almost now 2 years without any treatment, he is doing good.
okay, okay, right. Saurabh, Dr. Saurabh,
Yeah. So most common is
in your practice, I mean, what are the most common presentation? Because I just, I mean, the last 5 years I am practicing in Chandigarh area, so I mean, I hardly come across only 2 cases. So, what is your
firstly the what we have noticed functional is not so common. Most of the time
hmm,
they have a
functional?
mass or a local presentation. Somebody picks it up on the imaging,
Hmm.
and they end up with the surgeon or with us if it's metastatic and the biopsy shows us the report grade 1 or grade 2 also. Most of the time we don't have much of a symptoms, mostly asymptomatic. Occasional patients may have maximum maybe obstructive symptoms, sometimes related to the obstructed syndrome, but very rare. I mean, I would have had hardly an entire thing, 2, 3 patients that come with some which we could
Okay,
have ascribed to a obstructive, I mean, the functional secretions. Never
okay,
in a crisis. Never seen a patient in a crisis
okay.
with this.
Very, very right. So, most of the time they are, dormant and they are incidentally detected. So majority of the time.
Yeah.
And so anybody of you, any one of you came across in a cardiac carcinoid, anybody, and how they are presented? I mean, anybody has experience of dealing with the cardiac carcinoid syndromes? Dr.
No.
Bowman.
You mean endomyocardial fibrosis type? No, these
Yes,
have
sir.
not.
Yes, sir. Uh-huh.
We screen them many times with a 2D echo and everything, but to tell you frankly, it looks very rare. I have not seen it really.
Okay. Right, sir. Right, sir. Next slide, please.
Common.
Rashri. Yes. Any inputs? Any inputs, please? Anybody want to?
Nothing. I mean, generally what we do is 6 monthly, we send him for an 2D echo and cardiac evaluation. Never seen it till now.
Okay, right. So, I mean, again, a majority of the time, it depends upon what is the site. So, majority of the time, they presented with the abdominal pain. I mean, 28 to 79%. They may present with the bowel obstruction also, intussusception, or if the ileocecal region is there, diarrhea, carcinoid, heart disease, flushing. So,
Mesenteric
depending on the
fibrosis.
site.
Mesenteric fibrosis is one of the known complications of long-time neuroendocrine.
Yes, sir. Yes, right. Very right, sir. And bronchopulmonary cough, hemoptysis, and recurrent infection. Next slide, please. Very right. So abdominal pain is the most common, and we have discussed this clinical feature of functional NET. So depending upon the site and what are the hormones they are secreting. So I mean, anybody come across with the gastrinoma, gastrin, or glucogonema? Anybody has experience in treating insulinoma? I mean,
Yes, sir. Insulinoma. When I was in MD, I was working in a very high volume endocrine center. So we used to have a lot of insulinoma cases. They do present with recurrent hypoglycemias and some of the
okay.
very weird features. So there are patients we have encountered who were diagnosed because of recurrent cerebellar symptoms. Also, we published a series also with my boss. So insulinoma used to be, it's not as common, but if you're working in a very high volume endocrine center, you can encounter. So yeah, it is common.
Oh, okay.
So I had a glucagonoma, sir. The patient had presented to a dermatologist with skin
Uh-huh.
rashes going on for a long time and nobody had picked it up. Finally, the biopsy, it was actually something like a necrolytic migratory erythema and then evaluated by our endocrine and then found to have diabetes and retrospectively we found she had an NET. So she
And
underwent PRRT, survived for a long duration. We had given Captem, then even the octreotide, everolimus, survived almost for 5.5 years, I think. Then she had ascites, decompensation, and finally expired.
finally expired. Okay.
Yes.
Right. And because an experience with the gastrinoma, VIPnoma, somatostatinoma, I mean, I just want to have a, just inputs from if somebody has experience. I didn't have any experience. Sir, Bowman, sir?
I have seen gastrinomas, and many times they are a part of MEN also. Part of
MEN.
as a part of MENBC, and the
Mm-hmm.
treatment remains the same. You start off with
So,
sandostatin only, and
so
they most of them they would respond.
okay, they do respond. So, are we routinely
And then the serum gastrin levels are important for us to monitor.
serum gastrin level? Okay, right. So, Dr. Jayashankar or any one of the panelists can take that. So, are we routinely screening the patient for MEN, MEN 1, MEN 2? Do we screen, Dr. Jayashankar?
Uh, Routinely, we are not doing such.
We are not doing it.
We are not
Saurabh?
doing
Saurabh?
any history of family history or
Okay.
dual malignancy like things. Then we'll think of.
There's a parathyroid hormone secretion. You should screen for MEN
Yeah,
We should
exactly.
because
screen.
parathyroid is a very common thing associated with any of these neuroendocrine.
Okay.
Yeah.
Okay. Roop Jyoti?
Hyperparathyroidism is a very common thing. Once we have that, we do it. Or if there is any family history, sometimes not very common with these situations. More common is if there is a parathyroid secretion, we should be screening for these patients.
MEN.
Or as multiple symptoms and multiple times they have done it, again, try to screen for MEL.
Okay. Dr. Roop Jyoti, what is your protocol in Guwahati?
Yeah, hi sir. So routinely we do not screen unless the patient has a family history or multiple primaries.
Mm-hmm. Oh, okay. Roopjyoti, do you have any experience because you are practicing in Northeast area? So, I mean, do you have any experience of, out of these tumors? I mean,
So functional tumors as such are very rare. So as oncologist, I have not seen, but while I was doing MD, so at that time I have seen one insulinoma.
insulinoma. Okay.
Yeah.
So, insulinoma everybody has seen, glucagonoma madam has seen, and so remaining, okay, for theoretical purpose. Okay. Next slide, please. So, I mean, So what are the common tests which we do for the neuroendocrine of to localize the primary site? So what is your practice, Dr. Siravali? If you are suspecting some like the patient is entire gut is studied with the disease, and what are the tests basically you do? You upfront you are doing the functional imaging, or you do the some other test?
Sir, it depends on what symptoms they have presented. Like if I find that, suppose let us take they have come with like multiple lung metastasis or something like that, which is there in the PET. However, the biopsy is saying NET. Is there something in the bronchus? Is it like a bronchial carcinoid or something we would think, or GI primary? So GI, yes, I would go ahead based on if some patients come with a biopsy upfront, sir. So if that makes our work easy, go ahead with the Dotonac PET, no uptake, do a PET. Usually we end up doing both PET and Dotonac.
Okay, okay.
Yeah.
Patent program, because
Yes,
it
yes,
yes, yes. Because majority of
yes,
the time they present with the with the secondaries, and so we don't know what we are dealing with
yes,
unless the
yes,
biopsy is there. Okay,
yes, yes.
Dr. Jayashankar, same. So we are ended up doing the both things. Yeah, Avinash.
Yes, sir. Most of the cases actually, when say, suppose liver mets are there, you have already asked for PET, then biopsy comes, okay, neuroendocrine. Then again, you are going and you are doing this Dotanoc PET and all. So mostly in patients, both the scans are being done.
Are being done like in the same
Mm,
case. So, okay, okay.
yes.
So we have also done the same. So anybody differ on this approach?
Just
So
one thing, that for lung carcinoid, the SSTR expression is very poor. For
okay,
a
sir.
classical carcinoid of the lung,
Hmm.
atypical have got high expression of SSTR, but typical lung carcinoid have a very poor expression of SSTR. So
Okay,
Dotanek
okay.
is not very good. Around only 20% will have.
Okay, so only the we have to rely on the biopsy and the PET scan, what, sir?
That's right. Or a
Okay,
CT scan, or a plain CT scan also there is.
plain CT scan, plain CT scan. Okay, uh, right, right. Thank you so much, sir. Uh, Next slide, please. So, first of all, yes, of course, as we have mentioned, the detailed history and physical examination, assessing the symptom to find out the site, and review the medical records. If the previous, yani majority of the time they are referred by the by the primary physician or the some other our medical colleagues. So we have to look for the previous imaging studies and surgical procedure if they have undergone. Next slide, please. So we have discussed, sir, what is the role of MRI in conventional imaging? We have talked about initial always majority of the time the patient come with a CT scan. And then when they find the this something unusual or they found a secondary, then this sent to the medical oncologist. So what is the role of MRI in in NET? And Dr. Siravali or anybody can take. Are we doing the MRI?
So not routinely, sir, but maybe if there is only liver involvement and few lesions and some ablation is planned or something like that, I think that is when we are using. Otherwise, we are not using it routinely though.
Okay, right, right, very right. Take it. And sir, Bowman sir, are you doing this EUS?
Yes, we are doing it for mainly pancreatic duodenal lesions. So we are doing quite a few. We are very active US department in Fortis Malone.
Uh-huh.
So any pancreatic disease, to stage the disease also for pancreas, we are doing very frequently US
Okay, 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 okay,
as a part of staging also. If the
okay,
disease is very localized.
okay. If the disease is localized, and then sir, if the disease is localized, then you are going for surgical resection.
Absolutely, absolutely. We
Because,
had recently a patient who had a mass around the pancreatic region,
mm-hmm,
and just on a routine scanning because the patient had to go undergo CABG or some cardiac for some cardiac issue, and
mm-hmm.
on the screening we found. So it was a very localized disease. We did a US and we found out that very localized disease, and we could do an FNSC from that. Our gastroenterologist could do that, and we found that it was a neuroendocrine tumor. So now we
Mm-hmm.
are thinking whether surgically to exercise or not.
Okay, okay. This is yet to be taken, but it's a localized disease. So, I mean, so what will the mode of surgery? So, what kind of surgery? It will be a frank Whipple as we do in the carcinomas, or it will be a
No, I think so. If it is a neuroendocrine grade 1 or 2, it may not be like a Whipple. It should be just clear margins. That is all.
Then that's all. So we don't have to. Okay. Right. So these are the three types of functional imaging: SRS and gallium dotatoc and FDG PET. So PET and gallium scan we are routinely doing. Sir, SRS scanning, optoscan, are you anybody's doing it, sir? SRS scan, any experience with that?
I think so. Just no. Octave scan, I think so. No, not really.
No, we are not. So we are sticking with the gallium dotatoc. Okay. Next slide, please, Rashri. Next slide. Okay. So histological and immunohisto analysis, as we have discussed. So not the FNSC, we need a very good core needle biopsy is preferred over the FNSC because for histological grading and immunohistochemistry and K67 and mitotic count to classify the tumor whether it is grade 1, 2 and 3. Okay, right, sir. Sir, any other ISC are you doing apart from synaptophysin, chromogranin, any other marker would you like to see, Abhishek? I think he's not there. Dr. Ronak?
Sir, Dr. Ronak is from Janavati.
Okay. And who else? Roop Jyoti, what are the ISC marker you are looking for?
So it's basically morphologically diagnosed, and secondly, to know the grade, Ki67 is good enough. So I don't think other CDX2 TTF1 will help us much. So basically, I'm okay with synaptophysin, chromogranin, and Ki67 for a
KIC,
complete
yes,
morphological diagnosis.
yes, sir. Majority of the time, in to be practical in the clinical practice, these three things are good enough. Dr. Bowman, do you agree with that?
Yeah. For diagnostic purposes, this is good enough for us.
This is good on the baseline. Next slide, please.
Ki67 is the most important for us.
Most important, yes, agree. Okay. So I mean these things we are not doing it. I mean NGS, circulating tumor cells, and molecular study can we distinguish between the pancreatic and small bowel genetic using. I don't have any experience with that, and I never required of doing these things to to do the diagnosis. Anybody has experience? I mean they can share. I mean circulatory tumor cell-free DNA, we are not doing it. Next
We are
slide,
not
please.
doing it.
Next slide, please. Okay, does anybody require for a surgical exploration to find out the primary?
So sometimes we may need surgical exploration, sir. So one patient presented with unknown primary and perigastric nodes, periduodenal nodes. So initially we did a chromogranin level. So chromogranin level showed some 400, 500 like that. So we suspected neuroendocrine tumor, and we are advised for only nodal dissection. We advised initially endoscopic evaluation. So we did a endoscopy 2-3 times. We couldn't get that primary. Where is the primary? We don't know. Then we told them we directly will go for a lymph node dissection. FNAC also proven. So FNAC neuroendocrine. Then we did a surgical exploration. Then during the surgical exploration, we found that duodenal primary. Then we resected duodenal primary along with the nodes. Now she is doing good.
Okay, sir, did we do any functional imaging in that patient? I mean,
We did a DOTA scan, but we couldn't find the primary. Small uptake was there, but after DOTA also we did a endoscopic evaluation, and we did a multiple biopsy from duodenum. All are negative.
So I mean that's very good. I mean it was a therapeutic as well as a diagnostic as well surgery.
Yes.
Some people do a laparoscopy before doing a major surgery just to see if there are any peritoneal mets or any fibrosis or anything.
Okay, screen laparoscopy,
Yeah.
yes. Yes, it depends upon
What you are
uh,
operating. What?
yes, but we are operating a center to center practice and how comfortably the oncosurgeon, what is his practice. But majority of the time when we are, doing it, check laparoscopies, majority of the time they are doing it. Right, right. Next slide, please. So classify according to the grade differentiation. In our practice, how do as sir has said, grade 1, grade 2, grade 3, depending on their Ki67 level and mitotic count. Next slide, please. Ki67 less than 3, 3 to 20, and more than Ki67 more than 20. Next slide, please. So this already we have discussed. So majority of the time it is grade 1 and grade 2. If it is grade 3, it is it is already neuroendocrine carcinoma. We have to treat like a neuroendocrine carcinoma. Next slide, please.
Now, excuse me, now the newer classification is in well differentiated also you have got grade 1, grade 2, grade 3.
Okay, okay, sir.
And then comes high grade,
Then
which is
come
which is neuroendocrine carcinoma.
neuroendocrine
So
carcinoma.
neuroendocrine neuroendocrine tumors, sorry, will be grade 1, grade 2, grade 3 in well differentiated. And
Okay,
then
and
comes, so recently I had a patient who was well differentiated grade 3.
okay, okay, right. And what was the Ki67, sir?
So in them the KI6 is around 20.
Around 20,
Yeah,
borderline. Okay,
yeah,
okay, okay, okay.
20,
Great.
25.
And sir, you managed with only this octreotide
No,
analog?
no, no, no. The patient had lot of extensive metastatic disease.
Uh,
She had, so in fact, I started with Folfox and Sandostatin. She was quite symptomatic, massive tumor bulk. And with God's grace, she has responded very well on Folfox with Sandostatin.
okay, okay, okay.
It was a GI, it was a GI neuroendocrine tumor.
Okay, GA. Okay, okay. Sir, why not EP protocol, sir? Etoposide carboplatin, sir?
So this is not neuroendocrine carcinoma. So
Okay,
when the Ki67 is say more than 55, you can consider as a neuroendocrine carcinoma. So
okay.
these are all Ki67 which are less than 20, 25, 30. Indom Captem is also one of the good regimens, I do agree. But this was, the patient was quite in a good general health and could tolerate Folfox. So I had started Folfox with Sandostatin and it was a
Mm-hmm.
well differentiated grade 3 neuroendocrine.
Well differentiated.
Uh,
Okay, okay,
So there is a classification now. In well differentiated, you have got grade 1, grade 2, grade 3.
great.
And then comes neuroendocrine carcinoma, which are all very high Ki66. And they are those classical small cell. And then we have got large cell carcinomas. And
Okay,
then we have got a mixed type.
mixed type. Right, 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 right.
Sir, if I may ask a question here. So what about those intermediate grade which are there, but they are presenting something like a high grade biology, like fastly progressing liver
Absolutely
metastasis?
right. So there
Yes.
is, so biology of the disease, as they said, is very, very important, for treatment decisions. We can start off with Sandostatin and see, and if they're biologically aggressive, you have to jump to Captem or some chemotherapy regimens.
Okay, okay. So, sir, in those cases, do you prefer cis ATO or would you prefer a fall
No,
fox, sir?
no, Captem. Capecitabine with
Okay,
temozolomide is the most standard treatment.
okay,
Or of course, Folfox or Gemox or something like that.
okay, okay, sir.
So
Thank you.
those are classical, well differentiated neuroendocrine tumors which have a high Ki67.
Thank you, sir.
Okay, right, right. Sir, even of the patient is having a lung NET also.
Yeah,
Uh,
lung NET again is very important. It's a different type of a disease. In lung
uh-huh.
NET, the Sandostatin and the SSTR expression being low, PRRT doesn't work well in them. Then
No,
everolimus is the way to go ahead.
everolimus and
You give Sandostatin, you give octreotide, of course. We give because there is lack of other treatment options. But everolimus is the way to, is the only drug which is good for lung NETs.
and what dose you use, sir? Do our patient
I
tolerate?
start off usually with 5 milligrams per day.
Mm-hmm.
And if they're tolerating well, we go up to 10.
Okay, right, 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 sir. Okay, and the next slide, please.
Sir, we have Dr. Mukesh and Dr. Rushabh also joining with us in the panel.
Okay, right, right, right. So let me ask. Let me take. Uh, Dr. Mukesh. Okay, Dr. Chaudhary has joined. Okay, sorry. Actually, it's not coming on my screen. Dr. Mukesh, I would like to ask, what are the scenarios in which you start the octreotide injections? Mukesh or Dr. Seali can take if she's there. Roop Jyoti, when you are starting?
Yeah. So basically, so as per guidelines, if the patient is asymptomatic or the tempo is very slow, then probably we can see the tempo. But in most of the time in clinical practice, we generally start with octreotide.
Okay. So for the symptom control, antiproliferative, effect and the advanced metastatic disease. Okay, and the yeah. So anybody is using in as a new adjuvant scenario in the perioperative use. What is the perioperative use? In what are the scenario in which we are using it preoperatively? Bowman sir.
Yeah, like I told you, for my patient who had a pancreatic disease, he doesn't want to start any treatment right now. He doesn't want to undergo a surgery right now. So in those
Okay.
patients, we had a tumor board meeting and we discussed whether to start octreotide or not in that patient. Because the patient was not ready for a surgery because he's really asymptomatic. So he says, why I should undergo a surgery when there is a small mass around the pancreas and it was in the pancreatic tail, if I'm not mistaken. Yeah. So so we are thinking whether to start octreotide in the meantime before he's ready for a surgery. But I thought patient asymptomatic, so I did not start him on octreotide. But we had a discussion whether to start. So some patients are
Well,
not ready for surgery, wants to wait for a surgery, you can consider. But I don't know. These tumors don't have, as we discussed, they have anti-proliferative effect. They will not bring down the tumor bulk so much. So that's why they are not so much useful as the
okay.
Sandostatin.
Center study is not much. Right. So on always it should be started with the with the discussion with the patient and with their family and what the
Right.
exactly patient wants and what is the symptoms.
Especially when asymptomatic, there is no role.
Okay, right. Next slide, please. So, yeah. Next slide. So what are the factor influence our choice for the octreotide and lenalidomide because we are having the most experience with the octreotide only. So anybody differ on that? Anybody has used lenalidomide? Because most of the trial which have happened so far, they have included octreotide only. Lenalidomide, I don't remember that in which scenario we can use. Anybody? So next slide, please. Next slide. Because the longer clinical experience, strong evidence from mid-gut NET, the PROMIT study, and cost effectiveness, potential for the combination therapy, as Sir has said, as Sir is using with the Folfox and or it can be used with mTOR inhibitors as well. Next slide, please. What is the long-term benefit have you observed in patient maintained on octreotide therapy? Sir, this is the question again and again coming. Like, how long we need to continue that?
I would think of till disease progression.
Until the side effects or
There were
disease.
one or two patients in last 4 years, 5 years they are taking octreotide, and the disease is, and patient is doing his routine work, everything, and he just comes, takes one injection of octreotide and goes. So there are one or two patients, they are with me for last 3 years, 4 years. Means even if I want to stop now, some patients, will continue.
We will continue. Right.
Because the disease is like static.
It's static. Yes. This injection is also static, and the disease also
Yeah.
becomes static. So we not. Dr. Jayashankar, the same practice we are doing it. Dr. Siravali. Yes.
Yes, I also would like to continue till disease
Or
progression. Yes,
progression
I agree with Pawan sir.
or side
Yes,
effects.
yes, yes.
Next slide, please. Uh, I mean, extend beyond symptoms. Yeah, there is a evidence that the impact of octreotide extends beyond the symptoms relief. Yes. Next slide, please. So, as Sir has already been, although anti-proliferative effects are not very great, but it does have, and it is directly binding to the somatostatin receptor on tumor cells and directing the anti-proliferative effect by inhibiting the cell cycle growth factor effect, pro-apoptotic effect. Next slide, please. Next slide. So, sir, what is our sequence in metastatic NET? So, as I discussed that my patient is now doing well. So down the line, if he progress, what are we are going to do? So, Dr. Jayashankar, what will be your approach?
So my approach is in metastatic disease. Usually we start with
Sanderson.
Sandostatin
Okay.
Sandostatin analog. Then we have one patient started with active-tide, and during active-tide, some progression was there after 7-8 months of treatment. Then we started with PRRT therapy. PRRT therapy, 4 doses of PRRT therapy was done. Then there was some disease control. It's a stable disease. After we done it once in 2 months. So 8 months, after 8 months of therapy, the patient had a stable disease, and the problem is bicytopenia. Then patient slowly recovered from bicytopenia. Then after that, with
Okay.
PRRT therapy.
With PRRT. Okay, right.
With
Right.
PRRT.
Okay.
During PRRT therapy also, we are giving active tide in between. Then after PRRT therapy, then bicytopenia recovered. Then after that, we maintained with the active tide therapy. Then after some time, she progressed on active tide. Then we tried with the captain therapy. So captain therapy hadn't helped for a long time. Within 2-3 months, again progression. But now I don't know what to do.
Okay. Yes, sir. Any input, sir, from your side, sir? So, sir, how many session of PRRT we are giving? Rashidi, can you, put the slides on, please? Sir, how many session in generally we are giving? 3 sessions, 4 sessions?
Yeah, if it has to work, I think so it works in 3 sessions. Otherwise, should not continue.
Okay. Right.
You will get renal dysfunction, thrombocytopenia, all those things will start.
Okay, marrow get affected, right. Rashidi, can you share the slides, please? So, I think...
So it is like this. If SSTR expression is there, you think of PRRT. If SSTR expression is not there, you think of everolimus, cabozantinib, all those things.
Cabozantinib.
It's a systemic disease.
Systemic. We have to treat it like, okay, right. So PRRT only work when there is SSRT expression is there. Otherwise, it will not work.
Ondota, on DOTA. So there
Okay.
is another scan also called NDOTA.
NDOTA. Okay. Right, sir. Right. So, Rashidi, can you share the slides, please? The slides got disappeared.
Sir, actually, there was some technical issue with Rajeshri. I will share the slides. Just wait for 1 second.
Okay. Let me open that. Wait 1 second, please. So I think we have come to the end of this discussion. So if we are, what is the grade? Yes. So as sir has directed, we need to find out what is the tumor grade, whether it is grade 1 or grade 2. So if it is the grade 1, we have to we can go ahead with the octreotide LAR or some local therapy, or if it is the if the Ki67 is between 10 to 20%, or it is a very bulky disease, we can go ahead with the PRRT as well as this. Next slide, please. Next slide. And somatostatin. So both of the things we should be given. Next slide, please. Next slide. So, sir, when you are proceeding with the local therapy at your center, on the what is your, what is the molecule you use? Are you going ahead with the TACE or TARE? If you want to give a local therapy because you are working in Mulund Fortis Hospital, they are having a very advanced nuclear medicine department. Sorry, IR department. So, what is your practice there, sir? What is
If at all, it is mostly TACE.
TACE.
Yes, mostly if you have to use, most of them it is TACE.
TACE. Okay. Yeah. And so why not TARE, sir?
TARE, I don't think so works so well in neuroendocrine. The results are not so. TACE will debulk the tumor quite well. And what
Quite.
you require is debulking of the tumor, and that too, especially if the patient has a carcinoid syndrome, you know, where there is a carcinoid syndrome which is refractory and the patient is symptomatic because of palpitations, hypotension, you know, on flushing.
Mm.
Those are the patients, and when they are refractory and when they have a high tumor bulk. In fact, you know, this is one indication where interferon can be added to octreotide also as a systemic disease.
Okay. So,
So
see,
otherwise,
experience.
interferon is totally out and we don't use also.
See, experience matters. Yeah, I mean, it's an eye opener for all of us. So when symptoms are not controlled, so we can
Add interferon to octreotide also.
Okay, okay, great, great. Okay, next slide, please. Rashiri, next slide. Okay, so this is the NCCN guideline 2025 neuroendocrine tumor of the GI tract, lung, and thymus. So if it is a localized disease, so surgical cytoreduction or and plus the metastaticectomy, and surgical treatment remain the primary, I mean, mode of treatment. If the surgical cytoreduction is not possible, if a low burden disease, we can observe as well as observe with the imaging, or we can start with the LAR. We don't wait for the patient to get the symptomatic. And if the significant burden is there, depending upon the grade octreotide, we can start with that. And so what is the, okay, treatment part is over. So how do you observe the patient, sir? Like if you are planning to patient, if the surgical section has been done, so there is no role of adjuvant therapy. So how frequently do you monitor the patient, and what are the biochemistry, what are the labs value you want to see every time? Or we can, because we cannot subject the patient every time to go ahead with the functional imaging. So Momin sir, please.
No, I would just do a routine anatomical localization like ultrasound or a CT scan.
Mm-hmm.
Absolutely. Once in 3-4 months, a sonography, once in 3-4 months, a CT scan for first 1 or 2 years. If there are any symptoms, maybe think of Dotadec also. If there are any symptoms, or on a sonography or a CT scan, you find something, you can do a Dotadec otherwise. Dotadec just to see the disease. Otherwise, after a clear-cut surgery, patient asymptomatic, just a anatomical localization of the disease will be good enough.
Okay, clinical history and anatomical. Okay, so sir, I mean, so you are alternating with ultrasound, sometimes CT scan,
CT scan.
okay.
And that to first
Siravali,
1 or 2 years ago.
Siravali, what is your practice?
Sorry?
No,
Yes, so the same. I mean, I agree with Mohammed sir. We also stick to the same.
Yes, yes,
Yes.
we are. Yes, that is very important, because most of the time the patient insists us not only in the neuroendocrine tumor, when we are following up the breast cancer patient, also other malignancies, sir, PET scan kara lijiye, PET scan kara lijiye, and they feel offended when we are saying that PET scan is not a, no, should not be done so frequently, or it is not required. I mean, I've seen that patient are getting offended and changing the doctor. So because my practice is, we explain them chest X-ray and ultrasound abdomen is good enough, and but still some patient demands, and we may have to get it done, but it is not the standard of care, right? Next slide, please. Thank you. Standard protocol patient. What is your standard protocol? So I think it's 4 weekly.
Yeah, absolutely.
Yeah. So I mean, next slide, please. Follow up we have discussed, and subsequent. So is there is any role of dose escalation, sir?
Yeah, it's a good question. Octreotide dose escalation studies are there. Dose
Uh-huh.
escalation, but I don't think so it has worked in a big way. Dose escalation of octreotide. It has
Okay.
not worked in a big way.
Okay. Okay.
But there
Okay.
have been
Okay.
studies. I have not
Okay.
done it. I have not done in my routine
Yes.
practice.
So, sir, if we have just a theoretical question, I mean, if we have to do it, Rishabh, so in what are the scenarios in would you like to do the dose escalation? Anybody can take. Bowman sir, you can also shed some light, sir.
A very, very slow growing tumor, SSTR expression continuing there, and very slowly progressive tumor. I think so we can consider, and tolerance is good. There are no gallbladder stones, everything clear. We can consider 40 mg. But I don't know whether 40 mg is available or not also. So,
Yeah, I mean, I'm not seeing that. I'm not seeing.
We are using 20 into 2, sir.
yeah,
So we are
20.
using 40 mg.
Okay.
yeah, what you're right, Vijay Shankar. Yeah.
ET.
Okay. So, sir, if the patient well the gallstone, would you like to stop the therapy or like?
No, we have got it operated. Means if the
We,
patient is symptomatic, we have got it operated, laparoscopically removed the gallstones,
uh,
gallbladder, and
uh,
then if the disease is still there, we have continued operated.
okay, right. Follow up we have discussed already, and if the patient is asymptomatic, we don't require the functional study. And okay, I think time is over. Next slide, please. I would like to. So, I mean, do we see I mean, it should come from the, our program director. Is there any need for specific NET treatment guideline or registries? I think yes. I mean, for registries,
Obviously, yes.
we cannot depend
Obviously.
upon. Okay. I think Europe has the most substantial data on, guidelines on neuroendocrine tumor rather than NCCN. Sir, I mean,
Yeah, I
majority of
do.
the studies have been done in the Germany. I mean, majority of the time for the neuroendocrine, they have specific.
Sweden has got a very good MEN directory. MEN.
Okay,
Sweden.
okay. There in Germany, I know that there are specific center which treat only
Yeah.
neuroendocrine carcinoma. So definitely there is a need. Next slide, please. I think we have done. Thank you so much
Yeah.
for my esteemed panelists and Dr. Bowman sir for
Thank you.
sharing their experience and sharing our words of wisdom to us. So
Thank you.
interform, this is the thing which I have learned from you, sir, and a few further variety of data now. And I thanks to my all the panelists, our program director, Dr. Jayashankar, Dr. Siravali Bowman sir, and my other panelists, and Dr. Sharma, Abhishek Rishabh, and team MCure for giving us this opportunity. Although they're rare tumor, yes, we do encounter in our day-to-day practice, and I hope it will be useful. And I believe that earlier when we were training, we were only using the Novartis, I think, not Novartis, but now the more and more generic molecules are coming. uh, so people, I mean, they are equal, I mean, their biosimilar are equally effective. Sir, what is your experience on this? We are getting a lot of generics,
Yeah,
except
we are using quite a bit of generic. And we have to tell the patient this is a long-term treatment. So it should
long
not
term.
happen that you spend money in 3, 4 doses and then you say, I don't have money.
Yes,
So,
yes,
so there should be clear counseling with the patient before you start octreotide. That this is going to be there for a very long term.
for a
So
very long time.
oh yeah, emotionally they will say, no, sir, you start the best one immediately.
Best all care.
Yeah.
Yeah.
So in practice, I have seen that. So emotionally they'll say, but after 3 or 4 doses, they'll say, sir, now can we shift to generic? So at the beginning
Generic.
only, why not start with generic then?
Our generic is good, and I mean they are equally effective. I mean we have seen in chemotherapy also we are using
Yes.
rituximab for 10-15 years. They are equally effective. So okay, thank you so much once again. I
Sir,
think and
if I may get an opportunity, I had two questions. I think Bowman sir can answer. Sir, what are the indications wherein you combine a standostatin with chemo, sir? And those patients who progress on standostatin, do you prefer continuing that and adding everolimus or just a single agent
Yes.
everolimus? How do you choose?
That in that trial, I think so, everolimus with sandostatin was not used. But if the SSTR expression continues, most of us would continue to use sandostatin also along with everolimus because the tolerance is excellent of sandostatin as we have seen. So mainly it is the SSTR expression going down, then just use everolimus or cabozantinib. Nowadays, cabozantinib, the cabinet trial is there where they have shown a good role of cabozantinib also. In one of my patients, I have started cabozantinib now.
Okay, sir. Sir, and combining
so
chemo with octreotide, sir, when do you prefer? Something like
Yeah, like all those who have high, Ki-67 and those who have a neuroendocrine component also, which is significant. There is an SSTR expression, like my patient was liver metastasis. So this is Folfox with sandostatin I'm giving, and with excellent results so far.
Okay. So
And
any role
after
of
6 cycles of Folfox, I'm going to send the patient for PRRT to control the neuroendocrine part.
Okay.
and
Epithelial part we have controlled with Folfox very well. The disease is coming down, but PRRT expression still persists after 6 cycles. Means we have finished about 5 cycles, in fact.
okay, sir, are you combining PRRT and with chemotherapy together, or
No. Only PRRT. No. PRRT
only
with chemo, they will not tolerate.
they will not tolerate? I mean because cytopenias. Okay, right.
Sir, any role for immunotherapy, sir, like durvalumab or
Yeah.
anything with?
There is no major role, I think so.
Okay. Okay, sir.
So far, I don't think so.
Sir, sir, Rushabh this side. Sir, when to consider cabozantinib everolimus versus Captem once patient has progressed on LAR, or if it is SSTR negative upfront?
So if the Ki-67 are quite high, chemotherapy may be a better option. When I know Ki-67 around 20,
Say
20 or
20 to
so.
55, somewhere between 20 to 55, go for Captem. If it is
Captem.
more 10 to 20, go for
Around 20,
everolimus or
25, then
cabozantinib.
Captem. If it's less than 20, Ki-67, most of the time it is cabozantinib or everolimus.
Okay.
Sunitinib is also there, but I think sunitinib is going down now with cabozantinib coming.
Okay. Any other questions, sir? Any other from my panelists? Any other questions?
Yes,
Yeah,
there
I
is
have one
one.
question.
There is one question from the audience, and we are honored to have more than 50 plus audiences with us who are listening to us. So, one question was like that: what are the common comorbidities associated with the development of neuroendocrine tumors, and how do they influence the type or location of that tumor?
Comorbidities. Sorry, I didn't get comorbidities
Yeah.
in neuroendocrine.
Yes, associated with development of those tumors and how to influence the type and location.
Like obstructive jaundice, they may present if it is around the pancreatic region. They are associated with pancreatitis, amylase, lipase being high, pain in abdomen, gallbladder calculi. We have seen patients long term on those. Cardiac issues not seen, but they are mentioned in the literature, obviously. Other comorbidities are loose stools. Now, recently, only one patient came with severe loose stools, hypotension, and repeated episodes of that is carcinoid syndrome. So those are all comorbidities only. Once they develop carcinoid, they get loose stools, they are hypotensive again, liver functions get deranged a little bit. So those are something which we do see directly associated with carcinoid. Otherwise, if they have diabetes, all those are obviously there.
Right.
And parathyroid related also. I mean,
Yeah, hypercalcemia. Yes, absolutely. If that is hypercalcemia, we have to look for parathyroid.
Parathyroid. Yes, sir. Yes, sir. Right.
And
I
MEN.
think Roop Jyoti has another question for you, sir. Roop Jyoti, you have some question, I think.
Yes. Sir, grade 3 NET is a very heterogeneous disease. So K67 ranges from 20 to 55. So do you, in your clinical practice, sense therapy based on K67 in grade 3, lower K67 versus higher K67?
Yeah, I think so. What you should look at tumor bulk. If the Ki-67 is high and tumor bulk is high, patient is symptomatic, you should consider upfront chemo. And sandostatin expression is there, you go ahead with sandostatin, octreotide. You go ahead with octreotide, but along with octreotide, as I told my patient, you start chemo. And whichever, that will depend on what the patient will tolerate chemo, Captem or Folfox or what.
Okay, thanks.
Okay, right.
Yes.
Is there any other questions? I think so. Today is Saturday, so I think we have done.
Yeah, we have surpassed our time, but again, we are bound by that. Thank you to all the audiences, first of all, for your valuable time and engagement. This workshop definitely has sparked many meaningful discussions. I won't take much time, but on behalf of the entire organizing team, thank you. Thank you to our course director, Dr. Baman sir, for your guidance on the cases, and our moderator, Dr. Deepak sir, and our speaker, Dr. Jehan, for your invaluable insights as well. We are deeply grateful to our distinguished panelists. Definitely, it all to all your expertises and contributions. It has enriched our understanding in many ways today. So let's continue and contribute and innovate as we work towards improving the treatment outcomes and transforming the healthcare together. So that's all from our end. Thank you all and very good evening ahead.
Okay, thank you so much. Thank you so much. Good night.
Thank you so much, everyone. Bye.
Thank you.